Hi everyone, good evening, and thank you for joining us during World Breastfeeding Week for an infant feeding update. My name is Lauren Thomas and I'm CPD Program Officer with Central and Eastern Sydney PHN. I also have my colleague Jane Miller, who's also on the line. I would firstly like to acknowledge the traditional custodians and sovereign people of the land across which we work. I recognise the continuing connection to land, water and community, and I pay respect to elders past, present and emerging. And I also extend that respect to Aboriginal and Torres Strait Islander peoples who may be joining us tonight. At the end of the webinar, we'll have an evaluation survey, which will be available in the chat, and it will also pop up in your internet browser. A follow-up email will also be sent with the link as well if you missed that. We really appreciate your feedback. Please complete this to allow us to issue certificates of attendance. Today's event has been RSCGP accredited for 1 hour of educational activity. To qualify, you'll be required to attend tonight's session in its entirety. We'll also have a post-webinar activity with 1 hour of reviewing performance. We will submit those activity hours on your behalf once they've been completed. Please allow a couple of weeks for us to do that. We'll also, if you have any questions for tonight, please put them into the Q&A box and we'll endeavour to get to as many questions as we can. And also we have some events coming up. So if you're interested, please visit the CESPN website. And now I would like to introduce our speaker for tonight, Dr. Kavita Krishnan, who is a Breastfeeding Medicine Specialist, Perinatal GP and IBCLC. Before becoming a GP, she worked for 6 years in paediatrics at the Sydney Children's Hospital Network, including neonatal intensive care at the Royal Hospital for Women, where she also completed a diploma of child health with UNSW. She's passionate about improving breastfeeding support and education and provides free evidence-based information about breastfeeding on her website, www.letstalkbreastfeeding.com. She's also a antenatal GP shared care with RPA, the Royal Concord, Canterbury and Royal North Shore. And she's also a member of the Academy of Breastfeeding Medicine and certified in neurodevelopmental care and the Thompson method. Please welcome Dr. Kavita. Thank you for coming.
Thank you, Lauren. That was awesome. A lot of information there, but thank you. Yeah. Should I start screen sharing?
Yes, I've just done it for you. Thank you.
Okay. I'd also like to acknowledge the land that we're gathered on and pay my respect to elders present, past, and coming. Okay, let me start sharing this. Okay, hang on, I've got to give me a second, everybody. It is. Okay, is that good? Yeah. Can you see that, Lauren? Yeah.
Yes, we can just pop it into presentation mode. Yeah.
Okay.
Perfect.
So I'm really excited to see everybody here, and I know there's a varying degree of experience with this topic, but I'm excited for all of it. It might be a bit basic for some of you who already work in lactation and breastfeeding medicine and the perinatal area, but I think it's good to kind of just go over the basics anyway. Okay, so I'm going to go straight into it because I think I was a bit ambitious with what we're going to cover. Okay, so this is what the situation is at the moment. We've got in Australia, this is from a survey done, I think it was 2012, and it was 96% of women start breastfeeding and 83% quit before reaching their breastfeeding goal. Now, the reason this is significant is because the women want to do it, and anyone who works in this area has seen how they feel invalidated and they feel disempowered by not being able to meet those goals. So the question I have is how are we going to fix this? And this is the problem that I've kind of found myself trying to address. And there's a few things that I can identify. One is that we have a responsibility to spread evidence-based and anatomically correct information, and which we don't have at the moment. And that's largely due to the way women's issues have been completely sidelined in medicine. There's also some basic things. The benefits are well known for babies, but it's actually protective for mothers. So again, we need to correct the misinformation out there. And mothers are the most disenfranchised group in society. Their health is the one that gets left behind. And I'm sure we can all think of a lot of examples of this, so I won't go into it. I'm going to speed through these slides because I think everybody probably knows this. If you want me to go through it at the end, I'm happy to go back to it. Benefits of breastfeeding. These are just a few for the baby, the infant microbiome and its role in immunity. They're now, the current thought is that 80% of your immune system is actually got to do with your gut. It's super interesting. I'm going to put a little presentation up on my website about that soon. If you're interested, have a look there. But it's also about prevention of disease. So it reduces the risk of asthma, allergies, autoimmune disease, heart disease. There's a 30% reduction in childhood cancers. The list is exhaustive. Now, those numbers are a bit scary. So if you have patients who can't breastfeed, when you look at the numbers, it's risk reduction rather than the way it looks, that 30%. So just make sure if you have patients who can't meet their breastfeeding goals that they don't feel stressed out by it. The benefits for mother is it protects the maternal mental health, the reduced risk of invasive breast cancer, reduced risk of ovarian cancer, and so on and so on. We all know the risk of all the lifestyle diseases and gestational diabetes, diabetes type 2 and cardiovascular disease. So these are the basics that I see day to day, and and I didn't know actually. So when I was in peds, the reason why I asked Lauren to put that in there is because patients are always shocked that we don't know anything about this. And I didn't receive any training in breastfeeding or lactation when I was doing peds, and I didn't receive any when I was doing GP. And we need to change that because rightly or wrongly, parents are coming to us expecting us to know this information. So these are the things that I didn't know when I was in the women's hospital is breast milk amounts. So the first one is the breast milk amounts in the first week. In the first 24 hours, the baby needs a small amount, 5 to 7 mils every 3 hours. And by the end of that week, it increases to 60 to 80 mils. The second fact is transitional milk, which is not the colostrum, only comes in day 3 to day 5. And I put there are some conditions that can see a delayed lactogenesis, but we're not going to see that full milk until day 3. So it's important if you have patients that come to see you in the pregnancy during like shared care, I always let them know these things because it can say that they're so focused on the birth that often they neglect to really research what's going to happen after in that first week or two. Number 3 is also to know alternate ways of feeding. My mind was blown, and I didn't learn this again, but from doctors, I learned this from midwives at the women's, that there are other ways of feeding babies. So this was one I wanted to poll to see if you'd ever heard of cup feeding or spoon feeding or an SNS. If there's interest, I can go back to these. But in those early days where the volumes are small, it can actually be quite empowering for the parents to express into a spoon and give that to the baby. And we're talking the 5 to 7 mils will be a teaspoon or so. So that's one way of feeding. And the SNS is a system where you have a tube, it's taped to the breast with the opening just off at the nipple. I didn't bring my bag of lactation things. Anyway, and then as the baby latches, they will be stimulating the breast, and at the same time, milk will be drip feeding in through that little tube. So for babies that get tired or have an issue with latch, that's a way to preserve supply and also encourage milk to be produced too. And the fourth thing that we need to know, ways to protect the breast milk supply. So this is like, if there's one lesson, if you're not that interested in this time, the one thing I wish every person knew is that if top-ups are necessary, of course, we want them to have their medical top-ups, but please make sure a mother expresses with a well-fitting pump. And this is something we need with standardized guidelines and training, but too many times I've gone and visited friends or had patients come in and they've had an incorrect pump or they've not had access to a pump and they've not pumped at the same time. Now, before you go into these facts, it's really important to work out if the patient actually wants to breastfeed. This is something else that I suggest doing when they're pregnant, because if we ascertain their goals, then we can prepare for what they actually want to do rather than just feeling completely bombarded by all the information after baby's been born. This is just going into the colostrum and the transitional milk. I think the slides will come to you so you can have a read of that there. It's crazy what's in it. And this is, I thought, what actually is in breast milk. So another thing I wanted to say is I love the lactocyte. It's a pretty amazing cell, but it's one that we've completely neglected again in medicine. So the lactocyte is a cell that that's the one that activates and actually produces the components of milk. So the composition is robust throughout lactation. So whether you breastfeed for a week or whether you breastfeed for 2 years, it will produce roughly the same amount of the important nutrition that you need. So generally what we see is carbohydrates 7%, fatty acids 3.8%, and protein is 0.9%. And it's remarkable how that stays consistent. The rest is water, around 87%. And another little interesting fact is that this is species-specific milk. So for humans, this is the composition. But say for an animal like the seal, they have a way higher concentration of the fatty acids. And an animal like the aardvark, they have a way higher concentration of protein. And I know I sound like I'm just a bit of a breast milk obsessed person, but I think it's really important to change the way we think, because we don't think of it in the sense of a mammalian, thing. Excuse me, I have had a cold, so my words may not be as great. This is again the lactocyte, which is the cell. I'm going to go into it when I go into the anatomy of the breast, but this is a little bit of information about the actual lactocyte and how this cell gets triggered. So the lactocytes are always there, but they don't reach full maturation until the breast is developed in pregnancy. So this is how the lactocytes start producing milk, and it's about prolactin signaling and insulin, which is why a lot of people who have gestational diabetes or PCOS, we know that they have a problem with getting lactogenesis on that day 5. They usually take another 2 days to day 7, and it's because they haven't got the same insulin receptors in these lactocytes. Save that, all the insulin interesting stuff for another lecture. Okay, so these are some of the problems. This is probably a good spot to stop and say, Lauren, are there any questions that I should get to already, or to keep going?
Not currently.
Okay, all right. So I went into this. These are some of the problems that we see and that we need to be able to address, or at least refer on to the people who can address them. So these are some of the medical issues here. We've got low supply, breast hyperplasia, nipple difference, nipple trauma, mastitis, engorgement. Then there's issues with the baby in the second column. So tongue tie, hypertonia, sleepy baby, CMPA, hyperlactation, GORD. Then you have maternal disease. So there's a lot of things in there. I just put 2 common ones, thyroid and diabetes, and then retained placenta, postpartum hemorrhage. You can have vasospasm secondary to Raynaud's, and then there's something called DMAR, which is dysphoric milk ejection reflex. So I really wanted to highlight how much of a problem it is that we don't have a good way of addressing this really important 6 to 12 weeks in the newborn and the new mother's life. So right now I said we've left parents alone to navigate these things, and the problem is the nurses, the midwives, and lactation consultants have been picking up the slack for us as well. But often they come to us and we are undermining that, or we're giving conflicting advice. So we actually need to all line up and have the same advice. And we also need a multidisciplinary team to manage the situation. Is it peds? Is it OBS? Is it GP? Is it IBCLC? Is it a midwife? So these are things that we'll need to work out. And what I was trying to do is explain that you need to be able to manage maternal disease at the same time as managing the infant. For example, if someone doesn't have glandular tissue, we've got to be able to manage the baby gaining weight effectively at the same time as how can we optimize what tissue they do have, and also look after them disease-wise. And this was actually one of my frustrations in peds. I would often see the mother and baby, and I would see the baby and I would manage the baby, but then I would be like, go and see your GP or go and see your obstetrician for that after bit. Okay, so the way to classify breastfeeding problems is it pre-glandular, glandular, post-glandular, meaning the infant, or biomechanical? Okay, so I'm going to quickly speed through the basics so we can get to some of the issues. Okay, so this is the anatomy of the breast, and it consists of fatty tissue, connective tissue, glandular tissue. Now, this is all the fatty tissue there. This is the connective tissue, your Cooper's ligaments, which we need to rename. And inside here is the glandular tissue. This is all your alveoli in there, which are lined by lactocytes. Each of these are lined by lactocytes. There are 4 to 18 lobes, and each lobe contains 10 to 100 lobules, and the lobules contain 10 to 100 alveoli within them. And some of the anatomical discoveries, because we haven't really explored the lactating breast well enough, have been done by the University of Western Australia, the Human Lactation Research Centre. So we're the world leaders in some of this lactation research at the moment. So this is where I'm going to go a little bit more into the lactocyte. And this is the milk-making cell. And the tile. So this is the breast. And so we don't have good diagrams again, so apologies for the state of these diagrams. But these are the little alveoli in there, and this is a diagram of what it looks like within the alveoli. These are meant to be the lactocyte cells, and this is where the milk will come out of here. So it then gets excreted through the junctions and then is produced. It gets drawn down through the milk ducts and goes down through towards the nipple. The little red that I've highlighted there are the myoepithelial cells. So I've got a better diagram of that down here, and I haven't credited that diagram. I need to do that. But again, you can see that what happens is that's what the oxytocin actually does. The way you get that milk out of the alveoli is the oxytocin contracts and sends that milk down through the milk duct, and even part of the milk duct can contract too and gets it towards the nipple. There's a little bit more information there about lactocytes. Okay. So these are the breast changes that are necessary for lactation. Mammogenesis, which is the development of the mammary glands, and that happens during pregnancy. So from when the placenta starts, really, you have an increase of progesterone and estrogen, and you're having ductal elongation and lobular differentiation. So that happens, and by week 16, most mothers can produce colostrum. We don't want them to. We don't want any antenatal expressing at that stage, but they are able to actually produce colostrum at that stage. So lactogenesis is the milk production and maintenance. Lactogenesis 2 is the maintenance of milk. So that's the bit where we need to keep up the pumping to get the signaling right so that we keep producing milk. And that's regulated by hormones and breastfeeding frequency. And then number 4 is galactokinesis, which is the moving of the milk from the alveoli and the glands to the milk ducts and then to the baby's mouth. So these are the pregnancy breast changes, and they start from week 4 to week 5, and they prime the mammary glands for lactation. And I think I've just already mentioned that. Yeah, and yes, and the reason why they only produce colostrum and not massive amounts of breast milk is it's inhibited. The estrogen and progesterone actually inhibit the prolactin. So this is the physiology of lactation, and this is one of my favorite things. I think it's just incredible, and it's incredible that humans do it, and it's incredible that all mammals are capable of this. I also really liked endocrine when I was studying, so that's probably got to do with that. Okay, so the steps that have to happen: the baby suckles at the breast. There are receptors in the nipple. We're still trying to work out exactly how this happens. There's receptors in the nipple. They signal the hypothalamus. The hypothalamus then signals the pituitary to produce prolactin from the anterior pituitary, and I haven't put it there, but the oxytocin from the posterior pituitary. When you get the prolactin, that then signals the lactocytes to make milk. So we've got 2 steps there. We need baby at the breast to efficiently be stimulating the breast, and then we need that signaling to not be affected. So we need those nerve signalings to go to the hypothalamus and then to the pituitary. Then the pituitary needs to send that prolactin straight back down to the lactocytes. It will bind with the prolactin receptor sites, and then the lactocytes will do their thing. Now we've got milk. How do we get the milk out of there? That's when we get oxytocin released. And that causes the cells around the mammary gland to contract and release their milk and moves into the milk ducts. And this is what we refer to as the letdown. Little bonus fact there, the average person has 3 letdowns within 45 minutes, and most of the milk is collected in the first 2 letdowns. 20% of people will not feel a letdown. So I get that question a lot. Is it okay if I don't feel a letdown? Some people just don't feel it. Okay. Was there something under there? My tool No, there's not. Oh, yeah, baby suckles at breast. So I was just saying at the bottom there that the cycle continues. Okay. Oh, it's not turning. Okay. Did I miss a slide? Yeah. Okay, so then any questions on that part, on the physiology?
No, Kavita.
Yeah, okay. So then this next bit is the fluid dynamics of breast milk transfer. And this is where there's a lot of misinformation and a lot of confusion. So the way that the fluid is transferred is by vacuum, essentially. And the vacuum is created within the baby's mouth. The vacuum can also be created by a pump, or you could increase pressure and create a vacuum as well on the alveoli by pressing down. And I'm sorry, I do gesture to myself sometimes, especially when I haven't got my demonstration things around. So that's the way milk is moved from the breast to the baby. There's a little fun fact there. What I've got here is an image of the inside the baby's mouth. Now, this is the anatomy that we need to understand so that we can circumvent and manage a lot of the issues that we see. The two issues we're going to see are nipple trauma and a suboptimal latch. So in this image, this is the nipple. This is the hard palate there. This is the soft palate. And then this will be where the milk will transfer and drip down here. And this is the work of Dr. Pamela Douglas here. That is a picture from her study. So this is where it gets a little fun. I've got a bottle of water here. I don't know if any of you have water, but I think the best way to demonstrate some of it, to understand the vacuum, is to get someone to do it. When I do these lectures in person, I usually get someone to do it, but we haven't got that. So you're just going to have to see. What I want you to do after, or if you've got this, you can try, is get a straw. And I want you to practice and just see how you can do this. Put the straw in your mouth and try and get liquid, but do it with just your teeth. Don't make a seal. So like this. I know it's not attractive, but anyway, go do it like that and try and get air in. It's not possible. Then I want you to also try and put your tongue, when you actually drink, you'll notice that you push your tongue to the straw to manage the amount of fluid that you get in. Then I want you to try and leave your tongue at the floor of your mouth and see if you can regulate that fluid going in. You'll find that you might get a few dribbles in, but you won't be able to do it effectively. So what that shows you is the way that we actually get the fluid from the breast to the baby. The baby creates suction and creates that vacuum, and it has to have a good seal. If it doesn't do that, that milk will not transfer. And I've got here a little diagram that I made, which explains how it happens. Vacuum is created by the lack of air in a cavity. The lack of air creates negative pressure. Negative pressure enables fluid motion. Fluid motion occurs if there's a pressure difference between two spaces. So when we're sitting like this, there's no pressure difference, but as soon as you press or the baby exerts that vacuum, then you've got pressure difference. And it moves from positive pressure in the breast to the negative pressure in the baby's mouth. So that's the general thing that we need to keep in mind as a principle when assessing babies' latch and how they're transferring milk. I go into the elements of the intraoral vacuum here, and these are also studies which are done from our centre in Western Australia. And we've had this information since 2009, and we're not putting it into practice. And I see a lot of misdiagnosis because of it. I see a lot of missed diagnosis as well of issues because we're not assessing this. So this goes into just some of the technicalities about the position of the infant larynx. It's higher in the neck, which allows the soft palate and the epiglottis to overlap. The mouth creates a vacuum. The role of the tongue is simply to support the nipple at the hard and soft. I've got slides later coming with that, and it moves with the jaw. It was previously thought that the tongue actually had to strip the nipple, but we now know that that's not true. And I've got an image here. That's the tongue there. Sometimes I find hard to interpret. I haven't got the arrow in the right place, but anyway. So this, and I'm not happy completely with the baby's position here, but anyway, for the purpose of this diagram, it works. That's the tongue there. And in the next slide, I think I go over there. This is this one. This explains the tongue function in breastfeeding. The tongue does two things in breastfeeding. The middle of the tongue elevates the nipple to the junction of the hard and soft palate, and the elevation of the lateral aspect of the tongue, which means it cups around the tongue. I've got that same image there. So I was going to do this, but I think you can't answer for me, so I will just go through it. What is wrong with these attachments? These were 2 public images that I could find, and I wanted to have a look here to see just simple things that you can see that will, and the way I want you to think about it is to think, okay, how will this affect the way the baby is transferring that vacuum? And what we know is that baby cannot exert a really good vacuum that way. When they're older, they can do all sorts of things because their muscles are stronger, they've got stronger necks, but when they're little, they can't do it like this. So what the issues I see here is, firstly, this baby's hand is in the way. If you think if you're pulled away from your liquid, how are you going to drink? You're not going to be able to drink as well. So keeping the baby tummy to tummy would really help. The next issue I have is this chin here. The chin actually anchors. And again, I'm going to go to my water bottle demonstration and show you that when you're drinking, you can't drink without it being anchored. And I hope if you've got a water bottle, it's not just me looking silly. You have to anchor it somewhere. Usually we anchor it on our lip. Babies often will anchor chin and then open their mouth. So anchoring the chin is really important, and it gives them a good position and allows them to also extend the neck, which I'll go into in a little bit. So here the problem is the baby hasn't got the chin in the right place and is just not going to be able to exert a vacuum. And one of the key ways we can see that is by how much the baby's mouth is open. So we generally say it needs to have an angle. Oh, this is reflected. Anyway, it needs to be a 140-degree angle for them to have the mouth open enough so that that tongue can elevate and help the nipple get to the right place. In this one here, which is poor attachment, you will see nipple damage for sure, because where that nipple is going it's going to create problems. And again, if you have a look here, they've adjusted it here with the chin there, and there's a gap here with the chin. I would also add that if the neck is not extended, if you think, again, going back to our simple principles of drinking, you can't get the water down if you don't bend your neck back. You have to extend your neck a little bit to drink, and it's the same principle for babies. So now I've been talking about that junction of the hard and soft palate, which is crucial for nipple trauma. Okay, so if you're with me still, I want you to just put your tongue up at the top, just behind your teeth, in the upper row of your teeth, like that, and you can feel how hard that is. The nipple is very delicate, it's very robust, but it's also quite delicate tissue. If that rubs on that and has friction, you're going to get a nipple cut, nipple trauma very quickly. Now, I want you to put your tongue all the way to the back and up the top. So, where's this? Okay, no, there. So you're kind of aiming to go up there at the back of your mouth. You'll notice there is a softer part of your palate. If the nipple gets there, then it will not cause any nipple trauma, and you'll actually get a really good vacuum, and that baby will have a good flow, and you'll be away at a hack. So this is where these 2 slides come in, which is really important. And I didn't check if they're labeled at the right place, but anyway, so the junction of the hard and soft palate, it's about 5 millimeters beyond that junction. You want it to get right where they meet, and you can feel that yourself. And right behind there, it's super soft. So this is a bit incorrect, but this would be the hard palate all there. And then this is the soft palate over there. And the junction is this part in the middle there. I think when I enlarged it, the arrows didn't stick right. I'll fix that before the slides get to you. And again, this is a diagram from the Royal Children's Hospital, Melbourne, and they've got an image of a good attachment. And you can see, and this one's actually good. I don't know why I didn't include the other one, but it's got the poor attachment where you'll see, just my mouse, the nipple, if the nipple hits here, you will not get, you won't, very unlikely to have full supply because it will cause nipple trauma, and that will lead to inflammation. So where's the arrow? Yeah, so this is the nipple all the way back there. If you are wondering, how does it, if people have a 1 centimeter nipple, how does it do that? The nipple elongates 2 to 3 times its size, and it also increases in diameter. So it has erectile tissue, so it can do that. And under the stimulation of the vacuum is how you can do that. If we've got any mothers in the crowd and who had to pump, they may recall seeing that, or even breastfeeding, they'll see how the nipples can elongate massively. Now, we don't know why. We don't know the exact name of the tissue and the cells that actually do that. Anyway, that's my little issue. Okay, so this was about tongue function in breastfeeding. So this is, again, how the tongue functions in breastfeeding. And all it's got to do is lift that up. So we're obviously going to be getting to the tongue tie, the big hot topic. And this is where we've got ankyloglossia or tethered oral tissue. The Academy of Otolaryngology prefer the term tethered oral tissue because it's more correct. This just means fixed tongue. Ankylo is fixed and glossia is tongue. So it's a congenital anomaly where the underside of the tongue is tethered to the floor of the mouth by the frenulum. We all have one. I've got one here. Would you like me? Yeah, especially if you're not familiar with it. The frenula, really should have had other. Oh no, there's a good diagram there. Okay, there's a diagram here where that's a frenula, but that's a tethered one. In a normal adult, you'll just find a little bit of tissue that just connects your tongue to the base of your mouth. So, So what I want to talk about here is tongue tie is something that's always existed. It's always going to continue to exist. It's just a slight difference, in a variation in anatomy. And the rates, again, I've got these in another medium, of the rates of increase and how we're addressing the problem and how often we're getting them snipped have increased astronomically. And I wouldn't have a problem with that, but we're not seeing a proportionate rise in breastfeeding rates, which means we are doing surgical procedures without an evidence-based reason to do it. So I often say to patients, look, I can't tell you about speech. I can't tell you about sleep apnea, only because the research is not conclusive. But all I can tell you is for breastfeeding, whether this tongue is likely to cause you to have a restriction or be leading to an inability of your baby to pull that milk from the breast. So these are some of the symptoms associated with tethered oral tissue and breastfeeding. You've got nipple pain and damage. You've got difficulty, I'm sorry, these are in caps, but anyway, difficulty attaching the baby or they slip off the breast. A shallow attachment, milk leaks from the side of the baby's mouth on the breast or on the bottle. Poor weight gain or weight loss, long feeds and clicking sounds. Now, these are some of the typical ones, but I often will find baby, and I see many that have tethered oral ties that don't need revisions because they're gaining weight and because mum has no nipple damage. So those are the kind of markers that we want to assess together. This is also pretty exciting. This is done by a Kiwi across the pond. So this is Dr. Nikki Mills, and this has kind of revolutionized our understanding of the tissue. We used to think it was a submucosal band, but now they think that it's actually a fascial layer with overlying mucosa. So they think it supports, because it's not actually getting in this bit here, which is the muscle, they think that it may have less of an impact than we thought. I don't know if any of you saw the statement from the Academy of Pediatrics last week. One came out and they finally, oh, there's a chat there. Should I have a look at that? Oh, that's Lauren. And in the statement, they said there's also, you'll hear of lip ties and buccal ties and lip ties being inside here and the lips there. They generally don't affect breastfeeding. I've not seen one that affects the baby's ability to exert a vacuum. And that's also been the statement from the Academy of Otolaryngology since, I think, 2020. And the pediatrics have come out and said that too last week. Okay, so how do I move the slides up moving forward? Okay, so this is important for tongue function in breastfeeding. We don't have any standardized way of assessing them. There are 5 different tools. There's 5 different ways of even classifying them. I haven't got that on the slide here. I didn't want to go into too much. I could do a whole hour on, tongue ties, but I didn't want to go too much into that here. What I'm trying to get the message is that we haven't standardized it. So we really need to think about basic principles first and then have a look at the revisions. And I know there's a few lactation consultants here too, so I'm looking forward to discussing it and see if you all agree with me. Okay, so this is how I assess it. So we've got a thorough oromotor assessment, which can be done to avoid unnecessary interventions. It is a long assessment. I take about a minimum of 30 minutes to do a proper assessment because I need to actually watch the breastfeed as well, observe the feed, observe milk transfer and the swallow pattern, and assess any nipple pain or nipple trauma. I assess the mouth cavity, so the tone of the cheeks and the lips and the tongue, because often if there is hypotonia, premature babies tend to have lower tones, so they're not able to exert as good a vacuum. That can lead to issues. And using a finger, now this one comes in and out of, is this the right way forward or not? I do use a gloved finger and I put it in just the tip like that. Where's this? Yeah, I put just a little bit in and see if the baby can draw it back. And I don't stick it in and don't do much. I just want to see how the baby can move this tip of my finger into their mouth. And that's usually enough for me to see that they've got a good suck, and then we've got to just work on positioning. While I'm there, I check to see if the tongue is cupping and the tongue lateralization, and we assess the movement of the tongue. You may hear as well, and I heard this, and this is how I used to assess it as well, that the tongue should be able to extend beyond the gum line. But an ENT surgeon said to me, well, do you need to stick your tongue over your gum line to drink? No. So why would a baby? So that one's still neither here nor there, but it's just food for thought. Okay. Should we stop or keep going? Now we've gone for time. Oh, okay. We're running short on time. Okay, should I keep going? Yeah.
Yes, Kavita. Yep.
Yep. Okay. Okay. So the most common problems in breastfeeding, I hit the ones that I see the most often that we don't need too detailed assessment or discussion about. So the first one is a perceived low supply. Second one is mastitis or inflamed breast tissue, and the third one is nipple pain. So I can let you read all of this, but again, we need to just look back at the low supply differently. It's the second most common reason why mums stop breastfeeding. So they stop breastfeeding, 43% stop breastfeeding because of nipple trauma, 41% stop because of a perceived low supply. Its true incidence as a medical cause is 3 to 5%. I actually think that might be a little bit higher, but I haven't got data to back that up yet. So the medical causes will be due to either preglandular, glandular, or postglandular. So I keep going back to that because I think that's what we're missing in medicine. We think it's just put the baby on the breast and breastfeed, but there are so many. It's no different to the way the thyroid works. It's no different to the way our ovaries are signaled by the pituitary. So I think of it as preglandular, glandular, and postglandular. Postglandular is not completely correct. It's actually a completely different entity. It's the baby. So but that's how I roughly think about it. And then we've got mechanical, which is, did stimulation not occur as required to establish supply? Most mothers with a low supply actually will have adequate volumes, but we have no training and no understanding of newborn behavior. And I always tell parents that I think I was working in the NICU at the time when I had my first child, and I was around babies all the time, and I still felt overwhelmed. And I let them know that that's actually we actually have new neural pathways forming at that time. So I think it's important to let them know that it's normal to feel completely overwhelmed, and that in our current society, we don't have an understanding of newborn behavior, and that leads to a lot of misunderstanding with how to manage the baby. Okay. Now, medical causes of low supply. So these are the medical causes of low supply. So retained placenta, my nose is going to be blocked, but that's one of my favorite ones actually, because it's got to do with the hormones of pregnancy as well. I'll go back to that. I'll just quickly run through the rest of the list. Postpartum hemorrhage, sorry, I misspelled that. Sheehan syndrome or pituitary hyperperfusion, insufficient glandular tissue or breast hyperplasia. And you can see that with PCOS. You could see that with Turner's. You could see it with androgen insensitivity syndrome. You can see that you can see it for radiation exposure. You can see for many different reasons there. I put PCOS and GDM down there for insulin and lactocyte function. Maternal disease, hypothyroidism, not to throw one more fact in there, but the TSH also has a role in the functioning of the lactocyte, which is why it's really important to have that corrected too. And then we've got congenital issues. So the retained placenta, this is an important one because I see it maybe 1 every 2 months, which is due to retained placenta. And what happens there is the placenta is producing progesterone and estrogen all throughout pregnancy and cortisol. As soon as that baby's born and we have the placenta birthed, that causes a dip in these hormones. So once your placenta is birthed, if you birth the baby, those hormones are still there because the placenta is there. Until that placenta is birthed, your estrogen, your progesterone, and your cortisol will stay up. As soon as that placenta is birthed, they will plummet. It takes 3 days for that to plummet. And guess what happens day 3? The baby blues, where we get our milk supply come in. And the reason is because progesterone is inhibiting prolactin. So that's the normal functioning. If we have a problem like retained placenta, and it can be a partial retained placenta, it doesn't have to be a huge kind of the typical presentation. Even a small amount can do this because it's still producing the hormones that can inhibit the prolactin signaling and lead to a low supply. The way that presents, usually it'll be 4 or so weeks that the parent comes in, and I don't get it presenting the typical way, which is the fresh red blood or bleeding that has stopped and started or abdominal pains. Sometimes it is just this low supply, and a low supply while doing everything else, which means feeding every 3 hours or pumping every 3 hours efficiently. And we notice that this makes a massive difference. So if you are investigating low supply, and you've tried a few things and it's not working, I always suggest having a think about doing an ultrasound just to make sure there's no retained placenta. Okay, then nipple pain. How am I going to nipple pain? So this is the actual biggest reason why most people cease breastfeeding against their wishes. And this is one that it's hard to manage, and I feel nervous as I send them home, but it's one that is hugely important for empowering women to care for the babies the way they want. So nipple pain has 3 causes. 1 is suboptimal positioning, 2 is infant anatomical issues, 3 is maternal anatomy, or 4 is mechanical trauma from an ill-fitting pump. You'd be surprised at how often we see that mechanical trauma from an ill-fitting pump. Okay, any nipple pain has 3 consequences. 1 is pain. It affects maternal well-being, mental health, and bonding with the baby. You've got to remember we've got very high nerve supply to the nipples, areola, and breast. So it really affects mental health and bonding because they don't want to breastfeed. They're like, oh, I'm so nervous to do this, but they're getting this mental pressure to do it as well. So it creates a real problem. Then the second consequence is we get the inflamed breast tissue cascade, where if you've got nipple pain, there's now swelling. That means there'll be vasoconstriction as well, which means milk won't be coming out as effectively. Then you'll get the ductal narrowing, and I've got that little cycle there. And then the third result of nipple pain is a decreased milk output while they still have the milk in the breast. And that leads to mastitis, or inflamed breast tissue. So we have a new ABM protocol since 2022, and I'm actually super impressed by how everyone in Sydney is kind of aware of this. But if you're not, don't worry. I'm not aware of all the updates in a lot of the things that aren't in my wheelhouse. So that's why it's great to do this. So inflamed breast tissue. When I had my babies and I had mastitis, I was doing all the wrong things because that's what we did back then. So since 2022, everything has changed. We know it's an inflammatory process of the mammary gland. So we see it as a spectrum. It's a mastitis spectrum. It presents in one section of the breast, but it can occur across multiple sections of the breast, and it's associated with pain, swelling, redness, and often a localized area of tenderness. It's important to manage this early to avoid progression to a mastitis or a breast abscess. That's super key. We always want to prevent that. An abscess is more likely once there's any of the following. So a lot of the mastitis that we see, if there's no fever, it's more likely to be inflammatory mastitis as opposed to bacterial mastitis. And I've got a little flow chart here of how it happens. The lactocyte produces too much milk. You've got milk stasis. So this is if you remember, these are the lactocytes. I had to draw on top of it. This is excess milk. Milk leaks out of the cells. This is the surrounding tissue. This causes stromal edema. That means you get inflamed. The inflammation actually physically constricts those ducts, and that leads to stasis of milk, which leads to pain. So you can see that we actually need to solve the cause of this, or we won't fix it. Katrina Mitchell, who's a breast surgeon who redesigned this mastitis protocol, she says that when we give them the Keflex and the Flucox to treat the mastitis, it actually has an anti-inflammatory effect. So what happens is it improves it briefly, and then you get recurrent mastitis. If you have a patient that's had 2 episodes of mastitis, you can guarantee that they've got inflamed breast tissue, and we need to reduce that milk stasis. Okay, so these are the causes of inflamed breast tissue. Okay. So the causes are a shallow attachment on the breast. We've got an anatomical difference in the baby, which makes feeding painful. So a tongue tie can do that. So if you've got a tongue tie and it's putting the nipple up at the top of the mouth near the hard palate because the baby can't elevate or get the nipple moved to the right position, then that can definitely lead to nipple trauma. The longer gaps between feeding is a common cause. Excuse me. Pump shield size is incorrect. Suction settings are too high on the pumps. This is a big thing that people think. The suction setting, the higher suction you have, the more you're going to get. It's not true. They're very sensitive. If you have a vacuum, it will extract the milk. And overstimulation of supply due to fears of a low supply. So the management is to feed the baby on demand. Do not aim to fully empty the breast. Even today, I had a mum in today who, she's doing all really amazingly. And it seems if you've got a block, we should drain it, but it actually causes more inflammation. The analogy I give to patients is if they've got a big bruise on their thigh, if they keep on pressing at it and pressing at it, pressing at it, it's only going to increase inflammation. Breast is no different. So I've got more treatments and things. Again, you can refer to the protocols or to the ABM protocol, but the general principles are rest, ice, ibuprofen. Katrina Mitchell recommends evening primrose oil, and they use it for inflammatory breast cancer, but it's up to you if you want to use that one. Ibuprofen, and then you can minimize use of your breast pumps, only feed as baby requires, and fix the attachment or the underlying cause. We don't want any deep massage of the breast, and what we want instead is lymphatic drainage. Lymphatic drainage is the opposite of what we're doing, which is pushing down and trying to drain or get past that block. They want to move up towards the lymph nodes, and that's a diagram there. I'll skip this one, and we can go to, should we go to cases, or should we go to hyperlactation? No, okay. Should we do 2 cases, or should we stop for questions for a little bit?
We have a couple of questions, but if you want to do one of the cases, and then we can ask, because we've just got a couple of questions here.
Okay, sure. Okay, so the first case is X has just had her first term baby, birth weight 3.5 kilos, APGAR's 9.9. These are real cases that I had. I don't remember who it is, but breastfed at birth. She had some nipple pain on the left breast, but pushed through, and now she has a cut on that breast. The right is okay. Left hospital at 3.4 kilos. So she only lost 100 grams, and I can't remember what that is percentage-wise, but I think that's okay. Week 2, baby has a bowel motion once every day and is a little sleepy. He has some jaundice, but has periods of alertness. So we want to make sure that it's not jaundice and needs treatment. And he's had good, not wet urine, wet nappies. And bilirubin is well below the normogram level for treatment. Baby has not gained any weight within the last week. X started to pump after breastfeeding, and she heard that power pumping will help. She's getting 10 to 20 mils after breastfeeding on the right and 60 mils on the left breast. She's crying and upset that everything seemed good and is now not working. She wants you to prescribe domperidone. This is a case I get quite often, and I'd love to discuss it and just to see everyone's approaches and things. We can't do that, can we, Lauren? No. No. Okay. All right. So how to approach this? So the baby's weight gain is an issue. We want newborns to be gaining 30 grams a day. And that's a problem because this baby hasn't done that. Now, the other issue is the nipple trauma that's going to be affecting the breast milk production. And the second thing is the milk transfer on the right. And always for me, this is super important, is mum's mental health. I'm always adjusting my plans according to what mum can do, and any of the other lactation consultants will tell you that you can only do it according to what mums are capable of there. So this is the big thing that jumped out to me as being a big issue here. It may not be the cause, the prime cause. She may not be feeding frequently enough or pumping effectively, but we can see a big discrepancy here between what's produced in the breast. Week 2, I would expect there to be, each breast has a different storage capacity, by the way. You can store between 60 mils or 150 mils, depending on your own personal mammary gland capacity. So what we see there is that we've got a big discrepancy, and we can see that she's transferred milk on the right. So baby has been able to get that milk out. On the left, there is a problem. And what is the issue? So this is the way I always approach it. I always try and go to the feeding goals. The feeding goals can change. Even if mum's super passionate about breastfeeding, she can be overwhelmed, she can be scared, and she might change that. So I make sure that they're not under any pressure to feed a certain way, and I go into how they want to feed and why those are their particular goals. In this particular patient, yes, that's right, she had 4 years of fertility treatment. So it was extremely important to her to achieve this. And this type of patient would, you worry about how is their mental health and will baby gain enough, because they sometimes when they need to supplement, they really don't want to. Then feeding history, how often is mum feeding? How often is she pumping, and when is she pumping? Breastfeeding observation, I want to see the latch transfer. I want to see what the baby's doing when they get on that breast. And then we do a baby examination. So the mouth, the suck, the general exam, and weight. So it takes a long time. So I totally understand if people aren't into this particular field, but we can often get mums meeting their goals within a week or 2 by addressing all of these things and giving them a few things to shift and change. So there appears to be 2 causes. The first one was a low milk volume. And the question for me was, is it due to inflamed breast tissue due to the nipple trauma, or is it due to the lack of stimulation, or is it due to a glandular cause? So is she getting that nerve stimulus, so it can go up to the pituitary? 2 is the pituitary functioning and producing signaling. And 3 is a mammary gland responding. So that was how I approached that. And then the second thing is the poor milk transfer with the other breast. Is the baby tongue-tied, or is it a stiff neck? Now, I'm always nervous to talk about these ones, but so often this is what is the issue. And this is one of my common cases. This particular patient had the fertility treatment, and that's why I think I wanted to include this one. And she wanted the domperidone. I test the prolactin, and it's to help me decide whether or not to give the domperidone. If they've got a high prolactin, the domperidone is doing nothing, but affecting the mental health a little bit. So we know that they don't need help with the prolactin. And with her, she had an amazing prolactin. So it was a problem between transferring, and I'm going to get questions with that. But for her, it was a question between what is going on with this baby? Why is he not transferring on one breast? And what are we going to do about the nipple trauma? So the way, I don't think I've got the way I treated it. I've got it for the next one. The way I treat the nipple trauma, and this is again from Katrina Mitchell, she's kind of the guru, and all her protocols are available online. If you look up ABM protocol, whichever number it is, you'll see all her protocols there. She suggests kenacomb ointment for a nipple wound, and to apply that 3 to 4 times a day. No use of, I don't know if you've seen the silverets are quite common, but what happens is you end up with a macerated edematous nipple because they're just sitting in moisture, and that doesn't help wound healing with this particular tissue. So we want to air that out as much as possible, kenacomb ointment, and then also decrease any inflammation there. So the next thing is with this particular baby, they had a stiff neck on one side. And the way you can, and I don't know when I'm examining them, is it a stiff neck? But I can see when I've done my mouth exam, there's no tongue tie. When I watch the way they're transferring, there's no problem. On one side, the baby had a really good extension. I haven't got toys, but really good extension of the neck. That's where the neck is like this position to drink. But on the side with the sore neck, the baby kept it very stiff like that. And so that's an indicator that there was some uncomfortability there. The way to release it is the problem. We have some really good physios around me who I send them to, and often they get a release and then it fixes the problem. But we need to, of course, increase, awareness and training in this area too. I'd love to do a course, but I can't find one that I think is reliable enough to release that. So yeah, this mum ended up doing really well. She's exclusively feeding, which was super important to her. And her baby started gaining weight. It took 2 to 3 weeks to address the transfer. And the way we knew it was improving was because the baby was starting to become more comfortable with putting their necks back. Second case is mastitis and nipple trauma. So this one was baby is 3 weeks old. This is a very common case. It's quite simple. They've come to me. They've said mum's been prescribed Keflex by another provider for mastitis last week, but has engorged and open wounds on right and left nipples. I don't know why I've written include feeding type schedule pump. Anyway, I've written that. Baby is gaining weight. Well, sister-in-law family are very pro-breast. Oh, that was because this mum had a lot of pressure on her. She also actually had inverted nipples, which was part of the problem, but I think I left that out here. So this was just how to approach mastitis and bringing down the inflamed breast tissue. The good thing here is we don't have to worry about baby. Baby's gaining weight well. That's great. That's that one unit of this breastfeeding medicine we don't need to be concerned about. So now we just need to work on 2 things: decreasing mum's inflamed breast tissue and her nipple trauma. Her nipple trauma was due to the inverted nipples and a poor attachment, but most parents, it will be due to suboptimal latching. Okay, so this is just my information. If you need it, and if you ever have any questions, I'm all about. It's so hard for parents, so please reach out and contact me if there's any issues, or if you have any questions or you want advice. We have a breastfeeding doctors group, and we always messaging each other on there as well. I'd also love to have gone through the common position adjustments that I do, but we don't have time for that. So yeah, thanks for listening. It's a lot of stuff. It's heavy and it's kind of scattered to and back and forth. So I really appreciate everyone's attention.
Thank you so much, Kavita, for that amazing presentation. We do have a few questions. I'm just mindful we have a couple of minutes left, so we'll try and get to a few of these questions.
Okay.
So first question we have is there an example protocol to follow for mothers with reduced supply? Example, how often to express, how many top-ups to give breastfeeding, and how to calculate?
All right. So that's a really good question. Is there an example protocol? No, there's not. I'm trying to come up with one with the ABM, but what we do it by weight. Okay. So what we do know is in those first 3 weeks, you have to stimulate the breast every 3 hours. If you don't do that, you will not get a full supply. Parents always say, oh, what if my baby sleeps for 4 hours? I always want them to get that extra bit of rest, make up for it in the day. So that's the, hang on, move 1 second. Where did that question go again? Oh, it's gone. Anyway, so the protocol generally is in the first 3 weeks, they need to pump that often or feed that often. If they're not doing that, and you look at the output, so if they're not having poos, they need to have at least 4 to 6 poos a day in those first 6 weeks, and then their gut matures and that will slow down. So that's the way to assess it. But to increase supply, what I usually do is I assess their feeding plan. So let's say that mum, she was feeding and expressing immediately after. I always cut that out because it doesn't work with prolactin. You actually need to leave the lactocytes to fill up again, and then 90 minutes later you can pump or feed, and then there will actually be milk there, and that will increase it. I will also, if they're up for it mentally, I get them to introduce a nighttime pump because we have more, our bodies are more responsive to prolactin between 2 and 5 a.m. So that's another thing that we do. I can't see can you see the rest of that question, Lauren? I don't know if I've answered it properly.
Yeah, Kavita, it's just in
answered.
the answered tab. Yeah.
Answered. Yeah, there it is. How often to express. So if for a new mum, if they're worried about it, they have to do it every 3 hours, and how much top-ups to give versus feeding, it's very similar. So the content of formula has to be exactly the same. Now, it won't be processed the same because there are different things, but it has to have that 7% carbohydrates, that 4% fatty acids, and the 1% protein. So the way we do it is 150 mils per kilo. That's generally the calculation. So if I have a baby that's lost weight, so I had one that went down from 3.9 and had dropped down to 3.6, and that baby should have been about 4.2. I calculated 4.2 times 150 and then divided that by 8. Because that's where I needed to catch up, because I think that baby was about 4 weeks old. If it's like small on the smaller side, it doesn't need that same amount. So, but usually they'll all need around 600 mils of top-ups a day, a formula a day. But if your question is how much top-up do you give on top of feeding, that's a different thing. That's got to be baby per baby, and it's got to be judged by how much weight do we need to catch up. And also, I have a video on that Instagram of how to do pace bottle feeding. It encourages baby to be able to take the bottle in a way they regulate it so they're not getting overfed. Yeah, it's a big question. Again, I could do an hour on that, on how to deal with low supply. But if you have any questions, email me and we can talk about it case to case as well. I can see there, why doesn't the hospital deal with tongue tie before discharging the mother and child? I have a couple of patients. Because it's too hard to assess. Some mums leave within 24 hours. And not every person with tongue tie needs it cut. So that's why. What they need is an assessment to, is it affecting it? And most often, it's about the latch. I should have linked my video on the latch adjustments I do. It's all on the, what's that thing? The Instagram. I'll put it on my stories tonight. My young patients and my nurses help me run this. Don't worry, I have no idea. I'm in my 40s. So that's actually the thing with the tongue ties. And there's only 2 hospitals that actually really have a tongue tie clinic. That's the Children's Hospital and Westmead. And when I trained, I was doing them at the Children's Hospital, and we were using the Hazelbacker assessment tool. But until you can't assess it in 2 days to see if it's a problem. And frankly, if they've cut it that early, that really annoys me, because it means they haven't checked to see, can the baby actually do this without. And it annoys me because we're doctors, we have to practice evidence-based medicine. We cannot just go in and do a surgical procedure on the most vulnerable people without a reason. So waiting for an appointment. Wait. Wondering re-evidence for physio-guided therapeutic. Yes. So definitely there is, you can do therapeutic ultrasound. However, if you do the other things, you don't need to do that. For me, I'm always trying to cut costs for my patients. Physio is expensive. They don't get any postpartum care from Medicare. So they're already looking at another $150. They need a few sessions. And if they manage it with the rest, ice, ibuprofen, even primrosol, and the right behaviors, they will actually decrease that as well. There is a really good physio, Hayley Sheathers, that I recommend, and even the one in my practice, Elise Potter, they're fantastic for it there. Is this going to cut me off? Do I need to rush, or it won't cut me off suddenly? I'm rushing.
No, it won't cut you off. No,
okay.
Just got a couple of questions left.
Okay, good. Okay, that's why I was rushing through it. So waiting for an appointment for the hospital 4 to 5 weeks for tongue tie, the ability to breastfeed is lost by that time. Yes, it is. So in that case, you can refer them to Anthony Dilley. He doesn't assess them himself. He has a lactation consultant who does it, Anthony Dilley. And there's also a doctor in Bankstown. I'll find out his name and get back to you on that. He also does it. But they don't do it willy-nilly. They've started to do it privately because there's a need for it, and exactly what you're saying, people are waiting for that. But still, a tongue tie, I don't often see a tongue tie, and my patient population is breastfeeding patients who are having issues. I don't often see a tongue tie that needs to be revised. So most of the, and to be honest, I sent one last week for a revision, but that baby was actually transferring well, but they had very stiff, and mum didn't have nipple pain, so that baby made a liar out of me. But it was actually I actually rarely need to refer on for a tongue tie revision if we get the latch right. So that would be my take-home message, that if you can get the latch right, you will probably find that they'll be able to feed better. Now, is there an example protocol to follow for mothers with reduced supply? Oh, yeah, we've done that one. Under evidence. Oh, yeah, I've gone to the wrong column. I was told that Asian mums and those who had planned C-sections have further 1 day delay to milk coming in. Is this true? No, this is part of the racism that I see a lot in medicine and in maternity. Asian mums, including all the different types of Asians, what they're trying to say there is that it's gestational diabetes. And, you know, I had all my babies publicly. And I went to one of the clinics and they tried to immediately suggest that I had gestational diabetes. And I was like, look at my bloods. So there is a bit of that bias, which you need to be aware of, regardless of what your ethnic background is. It's definitely important to treat gestational diabetes, but no. The delayed lactogenesis is due to insulin receptors in the lactocytes. If their insulin and their sugars are under control, it shouldn't be a problem if they know how to stimulate it. The problem actually that I see with gestational diabetes is that these mothers are already shamed, and because people don't understand that all pregnancy will lead to increased peripheral insulin resistance. So everybody's at risk of gestational diabetes. So, but they're made to feel that it's their fault and they've already failed. So often what I see is that they're coming out of insecure, already feeling like a failure, and this is just one more thing that they can't do. And I encourage them, we can get them to Antenatal Express. Again, the evidence came out recently from the DAME trial that it doesn't change breastfeeding outcomes at 3 months. But I feel that it increases awareness of your breast and how to handle your breast and what it is, because most people don't go around, you know, handling their breasts. And that's actually the benefit of antenatal expressing. So with the mums that you are concerned about this, you should do that. But that's a perfect example of the myths. Do you know, people were told to harden their nipples before breastfeeding. And then there were myths that even how you got the idea of wet nursing and all this kind of stuff. Now, let me just also get to the planned C-sections. No, there's no reason to have a delay. There's no physiological reason. That's noted by the obstetricians, that's noted by the gynaes, and breastfeeding medicine is actually an established specialty in America. They've looked at the physiology. There is no reason why you should have a delay for C-section. However, you can have behavioral issues, not behavioral, but more circumstantial. So if the mum has a lot of pain, or she had a lot of drugs or a lot of fluids. For myself, I ended up with an emergency Caesar, and I'd had like 2 days worth of fluids, and I ended up losing a whole bunch of blood. But a mum that happens to who doesn't know what she has to do next, she's not going to know that she has to still feed and stimulate the breast regularly. So that's often what it is with and you're actually saying a planned C-section, but no, they just have to stimulate the breast and the milk will come in. There is some debate on with certain fertility treatments. Sometimes we see a delay in milk, and they're still investigating or studying, researching to see what that link is. Is one predating and causing the other, or is it just incidental that those two things can be connected? Guidance on motilium use, I definitely can. I have a fact sheet on the website. And I've got some good slides on the Instagram. Motilium is banned in the States and other countries. So it shows you that different countries have different things that they like. There's a lot of evidence to support using it for mothers of premature babies. But the evidence shows that even with motilium use, the maximum increase you get is 90 mils. The reason for that is usually due to behavior. So what I usually do is when they come in wanting motilium, I do a detailed history. And we go through why do they need it? Why have they, what's happening? Where is our issue? And I go through it that way. If this is not your area, I would suggest, getting them seen by a lactation consultant or sending them to one of the breastfeeding docs. There's 4 of us in Sydney, and we can always assess them for it. I am all about getting to the root of the problem. So I'm a little bit tougher to get motilium out of because it affects mum's mental health, and I don't like giving things that aren't needed. So that's my kind of take on motilium.